Next talk will be by Dr. Chitra Ramamurthy while she is getting ready to tell us on how to deal with an open capsule. I just want to stress on one or two things in the subluxated ones. When the use of dispersive OVDs, that has been very much under rated, because it will remain inside the bag and it will act like a nucleus piece. So if it remains there in the bag, it will open up the bag and keep it open unless you go there and aspirate it. So when you are doing a surgery, your aspiration flow rate has to be low. Bring it down very low and do slowly and refill the bag with dispersive OVD so that the bag remains dilated before till you get your CTR inside. CTR can be delayed as long as required. And the availability of these kind of instruments like micro scissors, micro forceps, CTRs and these rings, all those things have to be kept in a accessible place. As he was telling, searching for CTR where it is, so let us put IOL. So that feeling should not come. We should be doing it meticulously with everything available on call. Thank you, and over to Dr. Chitra.
Very good afternoon to one and all of you. I'm sure all of you are awake. Meenu Mathan's session deserves 200% attention of ours. And I'm really honored to be a part of this wonderful meeting which he conducts year after year. My due is to tell you how I dealt with some of the PCR moments. There are a huge variety of them which happened to all of us. And there is one controversial video which is also there. You can have your thoughts on that. Now, when we have a PCR, the first step for us is to do an anterior vitrectomy. And today we have different machines, modern machines have a cut IA and an IA cut mode. So in the cut IA, what you have to do is you have to start with the irrigation, and the second step in the thing is a cutter. So what it does is, it makes sense, there is vitreous there, so you need to cut the entire vitreous. Of course, you have tricot today which helps you stain, but sometimes you can do the preliminary part of the cutting without the tricot being there too, and check with the tricot in the end. And after you cut, then you have the cortex there, then you can go on to the IA cut mode. So in the cut IA mode, you need to have the cut at the maximum that machine offers, like 4000 in my machine, a moderate vacuum of 350 and a low flow rate. And then when you go, now you have only cortex there, then you go into the IA cut mode, wherein you go into the foot pedal 2 and you aspirate all the cortex. Again, if while aspirating the cortex you feel there is vitreous there, then you go back to cut IA mode. Now I'm going to show you one case here. Now this is a typical polar cataract. You see that clearing, there was a PCR. I've removed the nucleus. So now I go on cut IA mode and I go and remove all the vitreous, and then I go into IA cut mode. I could even do a dry aspiration without irrigation, and I keep replenishing with viscoelastic. And again I notice there's little vitreous, then again go into cut IA mode, then go on to IA cut, wherein I strip all the cortex. I can even cut the epinucleus so that I can get it all in one chunk. The ease with which comes, there is no traction, you know you're fine. But therein again a suspicion comes that there is vitreous, then you again go into the cut IA mode, cut all the vitreous. And the ease with which you can remove the cortex is an indicator that you have done a complete vitrectomy, and you look for the full support of the rhexis, and then you place your 3-piece IOL on the rhexis. Now we have the tricots available, which I use it as 1:10 dilution. Here now the IOL has been placed. I have no clue that there's a small PCR there, but I see that knuckle of vitreous at the incision. So then I go in at diluted tricot, I inject, and then I see that clearly that delineates the vitreous there. So I then do a vitrectomy and remove it, but then I don't go searching to look at the extent of the PCR. The lens is sitting well, it's stable, and I close my case. Now this is the first case which I'm going to show you. Now this is a well dilated pupil. Now moderate size rhexis has to be created. You stay in the capsule well. So everything is going quite well, and then I've started chopping. Now sometimes, as Dr. Meenu had said, the posterior plate may not cut separately, but anyways, my due is to discuss how I bring down my parameters to the last piece, because I know the PC is already well exposed, it can get trampolining into the probe. So then lower the vacuum parameters, things are going good. Now when I remove this cortex, I don't know whether you are able to see, there is a small oval PCR, a circumscribed PCR which has got created. No vitreous face is not disturbed. I inject viscoelastic to push back that any possible vitreous which could be there. And once I inflate, then I go in and inflate the bag. There's no cortex left. So now I'm going to inject my single piece IOL. Now that's just a focal area of PCR with no vitreous presenting. I don't see any need to disturb this vitreous phase, but the tricks are should not be rotating the lens. I should be injecting it into the bag to what extent possible. That there is a trouble I'm having in getting this haptic into the capsular bag, but then again I would not rotate it. I would gently nudge it in at that particular position. It's a toric IOL, so I'll nudge it into position, all the time being careful that I do not exert any pressure on the capsular bag, remove all the viscoelastic, and then yes, I would inject tricot to see whether I have disturbed the vitreous, which I have not. I get further clarified. However, I just do a gentle anterior vitrectomy for whatever it's worth and remove the tricot and get done with the case. Now this is the second case. Now I'm sort of lost attention and suddenly there's anterior chamber shallowing and there's a subincisional PCR and the nucleus starts dipping in. Now I know it doesn't look very good and aesthetically good, but I have to get this piece up. There is no vitreous as of now presenting, and I inject viscoelastic, get the nucleus right up, just enlarge the incision because the plan of action here is to place a 3-piece IOL as an IOL scaffold. I'm not clear about the extent of the vitreous with PCR. If I cannot visualize anything, I can leave the haptic on the iris, but if I get some clearing as I can now, I position the 3-piece haptic in the sulcus. There is a lot of vitreous there, but first my work is to do phacoemulsification. The lens will keep all the vitreous in bay. There's nothing much to worry there. And once I've eaten up, after of course coating the back of the cornea, I go behind and do all the cutting which I earlier described, cut all the vitreous and check whether there's vitreous in front of the IOL. And once I feel I've cut adequately, this is not more concentrated tricot, but anyway, the tricot has to be diluted and cut it. And once that is done, I ensure it's well positioned and that case is done. Now this is case 3. Now here, it's a very soft cataract, well dilated pupil. I've nearly removed everything, epinucleus. Then I see that small flap right in the center. Now I could have converted into a PCC, but it's too small a flap. So what I do is keep my phaco probe inside, go in through the side port, inject viscoelastic to push back the anterior vitreous face so that it's not disturbed. And then I'm going to inject my single piece IOL very gently into the capsular bag, just the way I said. I will not rotate the lens. I would gently nudge the haptic into the capsular bag. I would not overly stretch. I would not disturb the vitreous face. And once I have gently rotated and nudged the thing, now I'm going to go and strip all the cortex which is there. So here again, this IOL is acting like a scaffold, and then it is easy to remove. And there's no vitreous, so you can see the vitreous cortex is coming off easily. This is a very old case of mine where the patient had a centered IOL, came in later with this kind of a subluxated IOL. And now what have I to do? I have to get this out and place another IOL on the rhexis. But I don't just pull it out. I have to go behind the lens, do good vitrectomy because I cannot exert any traction on the vitreous base. Once I've done the vitrectomy, this is a very old video, so I would have injected tricot in the present day. I get the haptics out of the capsular bag, and once the haptics are in the sulcus, I would again go back and inject viscoelastic to coat the cornea and deepen the anterior chamber. I enlarge the incision just a little bit. And in this, I go and cut halfway through. If it's a hydrophilic lens, I can just pull it out hand over hand technique. I can cut it right through or I cut it half. And then again, hand over hand, I remove it. I'm paucity of time, I'm going to go on. Then I would inject viscoelastic, place a 3-piece lens in the bag, in the sulcus, and then I would check for any vitreous and cut the vitreous and get out of it. Now this is the case which is going to be a controversy for you all. I thought it was a well done case, high myope toric, the patient was going abroad, out of station in a couple of days. When I see something was wrong, the lens was tilting. So then I realized that no, there's no PC at all. I was quite wrong. But I did not have a battery of lens. He was a high myope. So what I do is I have to first get this IOL out because it was dangling in the vitreous. So I go in with my 2-inch dialing hooks. It is upside down, but however, I get it right up. Once I have done this, now I'm going to go behind the lens and do a good anterior vitrectomy, ensure that I've cut all the vitreous. And then once the vitrectomy is done, I have to go in, inject viscoelastic, and turn the lens up so that the haptics are well positioned. Now, I tell myself, I explain to myself, he's a high myo, he has a deep anterior chamber. So this haptic, though a little bulky, can be very well placed in the sulcus. It's not going to rub there. The challenge is in an undilated pupil state, the pupillary rough can rub on the optic of the lens and create pigment dispersion and intraocular pressure and CME. So here what I do is, after I wash off all the viscoelastic, I do an optic capture which sees that the optics is behind with just the haptics in the sulcus in a deep anterior chamber, and this patient continued to do well, absolutely bang on axis, 3 months, vision of 6.6 and was absolutely fine. Now this is the next case scenario. There's a PCR and there's a polar cataract and there's a strip of PCR, the typical one. I do an anterior vitrectomy, and once I have done that, I'm going to now, again, it's a toric IOL, I've promised the patient. There's enough place up and below. It's not a 3-piece IOL which I can force in. I gently nudge a single-piece IOL on the remnants of the PC above and below. And once I've done it and position that haptic to sit on that PC, area of PC which is there, I'm going to go behind and get the optic out. You need to have a smaller axis for this, and this is what we would call as the reverse optic capture. And again, then I ensured it is bang on axis, and you can see this patient, reverse optic capture, 6 weeks, is absolutely bang on, 167. The previous eye, 168. It's 1 year, and these patients are coming. They're absolutely fine. This is the last of my case, which I'm going to show you. Now, in this, in this particular case, this was a patient who had had a complete vitrectomy done, and it is like operating on an open capsule. There is that area where there's a lens touch, which has caused the cataract to form. So first and foremost, I would make a small rhexis. And then I would do a hydrodelineation as I would do in a polar cataract. And I nudge this small piece of endonucleus out, and then I eat it up with phaco. And now it is just that epinuclear shell there. So I'm going to do a visco dissection, go into the capsular fornicis, then grasp my epinucleus at tip, and it comes all rolling out. So everything has gone off well. Now all I have is just some cortex to strip, wherein, if you look carefully, there is that suspicious area on this temporal side. And I keep stripping, but there's no vitreous. There's no vitreous anyways, but then you can see that shiny silicone oil bubbling up there and coming there. So I wash it off along with the cortic aspiration, which I'm doing here. And then I place my 3-piece IOL onto the sulcus. This patient was anyway posted for a phaco and a removal of silicone oil. So I remove all the silicone oil which is there in front and leave for the vitreous surgeon to remove what is behind, and thus this case got completed. So that there are any number of ways, and so many ways each of us know. I just put together a few of them for you to understand that these are some tricks which we use to get bail us out and yet implant an IOL in the bag or in the sulcus. Thank you very much.
Thank you, Dr. Chitra. What a master class on PC rents, the different settings of PC rents and the ways to manage it to get a successful outcome. And she has shown post-op cases later. That is what is important. So we just do something and leave it, and later on what happens, we don't know. So if they remain like uncomplicated cases, those are the ones which have been managed very well. Congratulations. Thank you, Dr. Chitra, for sharing all this with us. We didn't see anything controversial. We don't want to discuss anything controversial. Come. So anyway, 2 things if you would have noticed carefully, even in the last video, the aspiration rate was very low. Reduce the aspiration rate, reduce things being pulled from different areas when you have a PC rent or a zonal dialysis, and always use dispersive viscoelastic into the area where you do not want things to come towards you. PC rent, plug it with dispersive. Zonal dialysis, open up the bag and push it away with the dispersive. These 2 things, keeping in mind, will change the scenario drastically in your practice.